almost quiet. We want to have all the time we can with Nadia. We're really, really pleased today to have Professor Nadia Sam-Agudu speaking, coming to us from the University of Minnesota, where she's the head of the Division of Global Health at the Pediatric Global Health Division in the University of Minnesota. And we're really fortunate that we got you on short notice and that you're willing to give this talk to us. Nadia has had an extremely interesting background. She had her BA, got her BA from the University of Virginia, and then her medical school at Mayo, then did residency and fellowship at the University of Minnesota, and then went to Fargo, North Dakota, because that's the place you would go for 2 years, where she was the only ever board certified pediatric infectious disease specialist for the whole state, and basically had to do surveillance, ended up setting up these clinics to increase access for immigrants and refugees, and at the same time ran a travel clinic and set up the HIV clinic. And if you know Nadia, this is not surprising. And then for the last 14 years, she's been working with the University of Maryland at the Institute for Human Virology, working in Nigeria, where again, she set up programs that help thousands of kids and adolescents throughout Nigeria. At the same time, because she's originally from Ghana, she has a bunch of pet projects in Ghana that she does on her spare time. And those of you who know her know in implementation science, she's actually set up this network, a really cool network of West African countries to improve implementation science in West Africa, because there's a lot less heavily built research in West Africa. And interestingly, we were just talking this afternoon, and you know, again, I don't know, she always happens to be at the place where there's a need. And so she had decided, or this consortium had decided, that they thought it would be important, I think 2 years ago you said, or a year ago, to set up a consortium to think about mpox. And if you've been following the news, they're really the only group that's poised to just step in and try and implement and figure out how to better set up systems. The other thing about Nadia that you have to know is that she was up till 4 in the morning thinking about all these various things. And she got up at 6 in the morning, of course. And she knew there was a GWACh picnic today. So she made, of course, jollof rice for the picnic, which is extremely hard in her spare time.
No comments from the Nigerians.
Her 2 kids with whom she's on vacation. Her here today on her vacation, helping us to learn more about implementation science. So anyway, she's going to talk about her excellent adventures in implementation science, which I think you entered in pretty accidentally. I don't think you were formally trained in it or anything. You just kind of became an expert by osmosis. But anyway, let you talk. We're so glad to have you.
Thank you. And we actually given an introduction that you probably did better than I would for myself. So thank you. So I'm really happy to be here. I know so many people at UW, and it feels like an academic home for me, really. And so I'm really happy to be here, and really this is my pleasure. So I wear many hats. I have 3 institutions so far that I am affiliated with: University of Minnesota Medical School, University of Cape Coast School of Medical Sciences, and then, you know, my long-standing institution, Institute of Human Virology in Nigeria, where a lot of my work is done, and we'll hear more about that. So I want to establish some expectations for you. Not expectations for me, but expectations for you. So know that I'm a Gen Xer, and I'm not ashamed to say so. And I'll make no apologies for any references I make with respect to Gen X. If you don't know what Gen X is, we are the people who were born between 1965 and 1980. You can find yourself on that spectrum anyway. So I have 2 Gen Zs in my house, and they throw me every day. But on a more serious note, I've learned a lot about health equity or health inequity and decolonization in health and medicine. And I've also learned how to have uncomfortable conversations about these things. And I hope, or maybe I expect, that you will join me to be uncomfortable together to talk about some of these things. So, starting off with the most excellent Gen X reference. Some of you might not even know what this movie is. Okay, this is how Keanu Reeves really came into, the spotlight. Okay, and it's called Bill and Ted's Excellent Adventure. Yes, I watched it, and I watched it on one of those things over there. What is that? So VHS tape, and I watched it on this contraption here. I had one just like that at home. So that's where I got my excellent adventure started, because really that's how my life in global implementation science has gone. So when and where did these excellent adventures start? And really, I'm just giving you a snapshot of the story, but I'll just start from about 2011. I got into Nigeria, started working in Nigeria about November 2010. So we are going on 14 years now. And but this is 2011. I'm in Abuja and I'm implementing PEPFAR pediatric HIV programs. I've been doing that just for a few months. And it had been 3 years since I graduated from my Peds IB fellowship, right? With zero implementation science training, no master's, no PhD. I practiced 100% clinical Peds infectious disease embargo, as Ray said, for 2 years. And I did zero post-fellowship research. So really, I'm just doing wonderfully well as far as research is concerned here. And I hear that the WHO is conducting a prioritization exercise for a call for proposals. And in this prioritization exercise, they're going to, for Nigeria, they're doing this in Nigeria, Malawi, and Zimbabwe. And in these countries, they were prioritizing the 6 most important research questions for which they would put out the call for proposals, So it was really context specific to each of those countries. So I heard this was happening, and it was focused on PMTCT, which if you're doing Peds HIV, you are also doing PMTCT, whether you like it or not, you have to do PMTCT. So, and it was called INSPIRE, as in integrating and scaling up PMTCT through something called implementation research. I had no idea what that was at that time. At that time, I'd heard of operational research, but I've not heard of implementation research. I was like, no problem, it's research, how hard can it be? All right, so I just want to pause here and just give some idea of how I think about intervention research versus implementation practice versus implementation science. And this is a slide I actually use to teach in the different trainings that I do in Nigeria and across West and Central Africa. I mean, we have intervention research, which, as we know, only focuses on efficacy, right? And effectiveness of an intervention. So the question that intervention research is asking is, does it work, right? And if it works, then we start calling it an evidence-based intervention, or EBI. But then now we go into implementation science, which the way I've thought about it is really where you develop and theorize methods to move evidence into practice and policy. So the question we are asking here is, what methods and tools do we need to accelerate use of evidence? And so those people theorize and develop it. And I really looked far and wide to look at definitions that really make a difference between implementation science and implementation research. I have not found any. People are just not willing to commit to making that. So I decided I'm going to write something anyway. So for me, implementation science, right, it does involve research and practice, but when we are using implementation science as implementation research, I think of the implementation scientists as really those people who theorize and create our theories, models, and frameworks. And the implementation researchers, which is where I consider myself, is where we systematically apply and study IS methods in the real world. It focuses on strategies for the evidence-based interventions to work in a given context. So the question we are asking is, does the EBI work in this context? But then how can we make it work optimally in this context? And that's where we come up with implementation strategies. And so implementation practice, and I was mentioning to some people earlier, that is not something we talk about a lot, especially not in Nigeria or other African countries I work in where we are talking about implementation science. We equate the implementation science to research. We don't talk much about practice. But implementation practice is applying evidence that is emerging from the implementation research to different contexts and settings to meet the unique needs of communities and people and to improve outcomes. So the question here is, how do we successfully implement the EBI in everyday public health and clinical practice in this context? So you see a lot of the questions are in this context, in this context, in this context. All right, so the people who practice these things are implementation scientists, implementation researchers, and then implementation practitioners or implementation support practitioners who can be a mix of clinical and public health providers, patients, policymakers. So for instance, in Nigeria, yes, I do implementation research. I'm an implementation researcher who has designed and led these projects, but I'm also doing implementation practice because I implement PEPFAR programs, and I support health facilities in implementing PEPFAR programs that are focused on children and adolescents. So now back to how I got into this field to start with, and this is how I was thinking about my strategic approach to my first implementation science application. So I was working with several in-country partners in Nigeria, and I heard about this prioritization exercise. So I called them and made sure that they were all at this prioritization exercise, because we needed to blitz this thing and make sure that we put in questions that we want. Okay. So I called them. And what did I use to call them? I had one of these top of the line, top-notch technology things at that time. I had a BlackBerry, okay? And rest in peace to BlackBerry, but I had a BlackBerry at that time. I had the first one on the gray one over there first, and then I was upgraded to this one, which literally died, and then it's somewhere in a drawer in my house somewhere in Ghana right now. But then that was an upgrade compared to what I used in medical school, okay? Cell phone became a thing when I was in med school. So I did most of med school without a cell phone. And when it came out, I had this exact phone and I shared it with my husband, like we both shared one cell phone. So my children think this is like not possible. I said, yes, this was the phone. And it was top of the line at that time, latest technology. So that was not a smartphone. And I've threatened my children many times that I'm going to get them this type of phone, given how much time they spend on their smartphones. All right, so back to the call for applications, so the prioritization. 6 priority areas were identified for the applications. Of course, there was strong input from program implementers because a lot of us were there. That's for HIV program implementers. And at that time, I already knew I had a half-written grant that was addressing 3 areas. And I made sure those 3 areas were part of the 6 questions. So it's good to sometimes have a very strong personality to get things happening like that. All right, so the proposal development and the feedback. The lead organization, I had that. I was working with the Institute of Human Virology Nigeria, which is a PEPFAR implementing partner in Nigeria. I had an in-country partner, that was the Clinton Health Access Initiative, Nigeria. Policymaker involvement. I didn't have that pre-award, but post-award, we were working with the Ministry of Health, the Federal Ministry of Health Nigeria. And then the study-based design, I had my EBI as mentor mothers, which is basically considered a behavioral intervention. And I initially proposed my intervention as a collection of client-suggested interventions, meaning that I was going to go to clients and ask them what they wanted in terms of PMTCT. I did not have any structure to that. It didn't even include anything qualitative. I didn't even know what qualitative. I just said I'll ask people to tell me what they want, and I'll sort of like rank them and make it an intervention. But it was struck down. So I went with Mentor Mothers. Mentor Mothers was one of the collection of client-suggested interventions. And I was advised to just focus on one because there was already evidence for Mentor Mothers at that time from South Africa. So study sites were primary healthcare facilities in North Central Nigeria. And if you know the hierarchy of sites at all, primary health facilities are like the most basic, simple. Secondary are like intermediate, and then tertiary are your teaching hospitals, big hospitals. And I said, well, if I'm going to do this and do this well, let me just go to the hardest places to do this with the least amount of infrastructure and in rural areas, because that seems really cool. Well, it was a lot of work, but I said that's because if I can do proof of concept in Nigeria over there, it should work in other places. So that was my approach. Implementation science elements, and this is usually how I go through an IS grant when I'm writing. That's today, but back then I had no theory, model, or framework. I had no implementation strategy. I had no implementation outcomes. And I had no hybrid effectiveness implementation design because I knew nothing about any of those at that time. But I was writing a grant. I wrote that grant. So I thought I had a winner on my hands, like really cool. I've been trained by somebody who is related to somebody in this room to write grants, very quantitative training. And I wrote it and I thought I had a winner. Well, not. So thankfully, WHO had a proposal development workshop where they would pick the highest scored or the shortlisted applications and take them into a workshop where they would further help us to develop our proposals to where they were good enough to fund. But the thing that they did that I thought was really just rough was that they only selected 2 out of that final 3. And I'm like, I'm not going to be one. I'm not going to be that one. I'm not going to be that one who goes home with nothing. So I was determined. I was like, it's got to be somebody else, but it's not going to be me. So, but we were picked out, 3. Our proposal was one of 3 out of 41 applications. And so that really was that proposal development workshop was my introduction to implementation science. And at that time, that was when I first heard evidence-based intervention and first heard formative research for the very first time. This is me after college, after med school, after residency, after fellowship, after working as an attending for a couple of years. This is the first time I heard about that, okay? And however, in my defense, it was very early in the IS field. I mean, Dan Schroeder et al. Had just published the CIFA paper, the first CIFA paper like 2 years before. Like, how was I supposed to know? You can't blame me for that. So here's a transcript of a conversation I had with a qualitative researcher who was invited by WHO to come to that proposal development workshop, right, to help us. So, hey, Nadia, your proposal is really good, but you don't have a formative research section. Formative research. Then I started to like, oh my God, I'm going to be that one who will be sent home. Yes. What is that? I honestly did ask her, what is that? Well, this is where you talk to people. You have to talk to people about your intervention. Why? I really did ask her that. I'm serious. Community and stakeholders and stuff is important. Well, I don't know how to do that. Who does that stuff? Social scientists. You should find one to help you. I don't know any social science. I really was like, I don't know where I'm going to find a social scientist in Nigeria. I said, oh my God, I have lost this grant. I came so close and I didn't get this grant. So, full on panic. But here comes my savior right here. You know him very well. So Prof. Lee Cornelius, he's a social scientist. He has a PhD in this stuff. And he was at the University of Baltimore at that time, which was also my institution at that time. And he had actually come to Nigeria to do some work with different people at IAV Nigeria. I didn't know him then. So I was told to contact him and, so I called him, trying not to sound panicked on the phone, and he's like, yeah, I do this myself. This is what I do. I'm like, you can have the entire formative study, like just take it and do what you need to do. So he actually came to Nigeria, worked with all of us and whatnot. He really taught me what social science was, what social behavioral research was. But let me tell you, he's very old school. He does everything manually. No deduce, no in vivo, no nothing. So I learned the really old school way to do this stuff. So at the beginning of this grant, so we were funded. I wasn't the one who was sent home. And it was a 5-year grant from 2012 to 2017. And at the time that we started, the latest data was showing how, bad of a situation it was for PMTCT in Nigeria, where you can see at the end of this graph here, Nigeria basically has the highest number of new child HIV infections, actually still is, and the lowest reduction in new HIV infections among children. So the highest number and the lowest degree of reduction. So we needed a lot. We still need a lot. So that's, our study was really important to try and find interventions or let's say strategies to mitigate this problem. So we had women living with HIV who were poorly identified and poorly retained in programs. And we had HIV exposed infants who were not being tested or tested late for HIV. So here I'm showing you the protocol paper for this project we published in 2014. And you can see Prof. Lee, my savior, right behind me right here. He and then another social scientist here, really right behind me, because they really helped me to make sure that this grant did not leave me, that I got the grant. So they worked with me on that. So we were engaging mentor mothers to provide lay peer support to women in navigating PMTCT services. And mentor mothers, if you don't know, already are women living with HIV who mentor other women living with HIV to navigate PMTCT services. So again, I'm doing this again. Evidence-based intervention was structured, trained, well-supervised peer support. And then the standard of care was really not no peer support, but we already had it in Nigeria, but it wasn't structured, it wasn't well-supervised, so I felt that we were underutilizing or under-benefiting from what mental mothers had to offer, but we had to structure it, which I've learned today is an implementation strategy. So I was doing it without knowing what it was, right? So study sites, 20 primary healthcare facilities in North Central Nigeria. To date, I've not had a study with that many sites. I don't know what I was thinking, but we had 20 sites, 10 intervention and 10 control. And IS elements, I still got the grant with no IS elements. No theories, models, or frameworks, no implementation strategy, no outcomes, no hybrid design. I don't think that will happen for me ever again. But we had a formative study, thanks to Prof. Lee. We did 11 focus groups and 31 key informant interviews among a total of 136 stakeholders, mental mothers themselves, policymakers, male partners, matriarchs in the family, things like that. So our primary outcomes, we had 2 of them because I had to be extra. I was the only one in the Inspire group who had 2 primary outcomes. Because a lot of this was focused on maternal side of it, right? So maternal retention. You find out later on that your funders kind of had a secret plan to make sure that all the projects were looking at least one type of outcome. I was like, well, I'm a pediatrician. I need to have a pediatric primary outcome. So I had a second one, which was timely infant presentation for early infant diagnosis by 2 months of age. And so in addition to the retention and the timely infant presentation, there was a secondary outcome that was very important, also the viral suppression at 6 months post-delivery. And note that this primary outcome for the infant, early infant diagnosis is not uptake of early infant diagnosis. This is a behavioral intervention where the target of the intervention is the mother of the exposed infant. Uptake of early infant diagnosis is reliant on the health system as well as the mother. Here we are only measuring at the point of the mother because the intervention, the mental mothers are only focused on the mother. So it is not fair to measure uptake, but the woman can control whether they bring the child to the facility on time. So we have to make that distinction. All right, so results, and then we'll talk about a few publications. The structured mental mother program was better. I think, if that didn't happen, that would have been a disaster because it makes sense, right? But we now have to measure it and show people that this is what it is. So it sort of ended up being like a 4, 5, 6 times thing. So 4 times better in getting babies to present for EID on time. 5 times better in terms of maternal viral suppression. 6 times better in terms of maternal retention in care. So we had a few papers come out. This was the first paper that came out after the protocol paper. So at this time we didn't have, the trial results, but we had some qualitative data. And today Mariam is a nurse. She's a nurse doing her PhD at university. And then these were the 2 sort of main papers out of the study relevant to the 2 primary outcomes, right? And then those were published in 2017. And then we have a couple of other papers, correlates of facility delivery for women in the Nigeria and the Women Nigeria study. And then one of my favorite qualitative papers to come out of this, we really talked to mental mothers and about how they work with the healthcare workers, because we thought it was all, hold hands and kumbaya. No, it was not. And so one of the quotes was that they don't see us as one of them. They don't see us as health workers. And so we published that as well. Gifts, I think you are very good. But then I just wanted to point out, we finally got something out in terms of an implementation outcome after the fact. And don't judge me because this paper was published, this formative research paper was published in 2021 after the trial results had come out, okay? Don't judge me. Okay, I still got that paper out because usually you want these sort of acceptability, formative study stuff to come out first, but look, I had a lot on my hands. So it was out, it's been published, it's there. So how then did I go, after giving you the introduction of how I got into implementation science, how did I go from no IS to I'm kind of not that bad at implementation science, all right? So from zero to not that bad. First of all, I got a grant that gave me no choice, right? The moment grant forced me to have to learn the stuff, and I actually enjoyed myself doing that. And then at the beginning, this was the first implementation science course I ever took. Thank you, UW. The fundamentals of implementation science, and I remember Kenny Sher was one of the teachers there. And then that UWIS resource hub, Kristen, you know I love that website. I have offered to marry whoever does that. I actually know the person who does that, and now it's very awkward. So I use that site from 2016, and really almost every day I'm on that site. I love it. It's really great site, so thank you. And then I also started teaching. You know, it's a great way to learn. Teaching is a great way to learn, right? You're creating content, you learn the content as you're creating it. And so I taught a couple of intro to IS courses at the University of Maryland graduate school from 2018 to 2022. And then also mentoring. I've been mentoring early investigators in implementation science. I was part of the last, there's this NIH TIDA group. I was one of the last sort of faculty in that. I learned a lot from that. And now I'm part of WashU's IRI as a faculty. And then, of course, lots of self-directed learning. Every day, every week, every month, I'm learning something about implementation science. Because I am not, as you say, classically trained in implementation science. I sort of had to scratch my way to learn what I'm learning. So I had to do a lot of self-directed learning, which, you know, I'm doing more of that than I would if I had a degree in it. Right? So, but then grants help, apparently, for you to learn things, right? So I wrote and implemented more implementation science grants. After I wrote the Moment grant we implemented, I was like, I kind of like this area. I kind of like this implementation science. Okay, let's write some more grants. So this is a snapshot of, these are all NIH grants, but there are a few other grants that I have, smaller grants in implementation science. But like in 2016, we got the ACT study grant. That was my first R01 with AHISA from Nigeria. And then I actually also ended up working on the ADAPT study, another R01. And then in 2022, I finally said, okay, I think I've learned enough about IS. I guess I can teach people how to do this stuff. So I wrote a training grant. It's in its third year of 5. It's called the EXPAND grant, expanding the pool of early investigators in implementation science in Nigeria. So, and then this is basically last week, we got the notice of award for UO1. It's actually, comes out of a CAWISA collaboration. I'll tell you about CAWISA from the next few slides. And it's, as you can see, from NCI, and it's looking at a behavioral intervention for cervical cancer screening among women living with HIV in Ghana. All the other grants I have before that are all in Nigeria. This is my first major grant in Ghana. So I'm really very happy to see that. And of course, reviewing grants is also helpful for you to learn more, and has been helpful for me. Reviewing implementation science grants for funders and abstracts for conferences. Once NIH starts funding you, they start asking you to do stuff. So I have said, okay, and I've been able to review some grants. You really do learn a lot from what other people are doing and are proposing. And then, of course, at the DNI conference, the Conference of the Science of Dissemination, Implementation, and Health, I have been working on abstracts as well. So another thing that has really, really helped me in my journey is being involved with Africa Focus, or LMIC, or Global Health Focus implementation science networks. For example, really the Nigeria Implementation Science Alliance, which was established in 2015, led by my colleague, the same person I wrote my first R01 with, which really gave me a lot of ideas for establishing a regional implementation science alliance. And then before that, AHISA was formed by Fogarty in 2017. And really it was I'd call it like a mini club of PIs and their partners who had been funded for adolescent HIV projects. I mentioned the previous slide, I had 2 R01s on adolescent HIV. So we all sort of came together, and what we're doing is just like a learning collaborative and a special interest group. Dr. Grisham Stewart is part of that, but I see she's sort of taking a step back and letting her people, learn from that. So it's been great to work with all these people who are doing adolescent HIV work in multiple African countries and some South American countries. So I think Brazil is also there. And then 2019, I led the establishment of the CAWISA, the Central and West African Implementation Science Alliance. That was September 2019. I did not know something was coming along 2 months later. And so really for the first year or year and a half, we couldn't do much. One of our faculty, what we call core mentors or local mentors, actually died from COVID in that first year. So it was really rough. And then more recently, after joining University of Minnesota, I've started attending meetings of the CTSA, Clinical and Translational Science Awards for advancing dissemination and implementation. We have a special working group, and it's been really good to really see what is going on, what has been funded, what people are doing. And I'm just really sort of proud of myself that I can hold conversations with these people, because some of them are really hardcore implementation sciences. So it's been great, a really great learning opportunity for me as well. So imposter syndrome always comes up, right? Especially for people like us who are not classically trained, as I said. But even if you are classically trained, you have a PhD or master's or whatnot, there are many times where you doubt yourself, right? Do I belong here? Am I smart enough? Am I good enough? Am I going to be successful and things like that? But think about these folks, okay? If they can get a Grammy, multiple Grammys for not even singing, you're okay. They're doing all right. I'm at least trained, at least, in some science. So don't feel bad. I kept the people who are my hype people close, and really in my mind, a hype person is someone who thinks you're way better than you actually are. And it's great to have those people. It really is. And I stopped listening to the you don't know Jack people. But while I'm not listening to them, I also made sure they were not right. Because sometimes they're actually right. I also made sure they weren't right. So I kept making sure that I was developing myself and improving myself. So I don't lip sync in my work. No lip syncing. If you want to do things and be well trained or well developed and have skills, you got to do the work yourself. Don't coast on somebody else's work or somebody else's success. And Gift has worked with me for a few years in Nigeria before coming here, and knows, what I say I know is what I actually know. What I publish is what I actually write. What I teach is what I develop myself. Okay, so I really try to stay true to, as I said, teaching is a very good way of learning. And I make sure that I'm doing all of this work myself and sort of carrying people along as well. So what we want to do, we want to get to A-team status. I told you there'd be a lot of Gen X references. We want to get to A-team status in global implementation science. So what lessons have I learned? And I'm not saying I'm at A-team status. I'm saying we want to get there. So that's also my goal. But I've learned a few lessons as I'm going on. And I'm going to bring a clinical medicine quote here, right? And I think it was William Halstead from Johns Hopkins, was a physician who sort of brought this quote up. You see one, you do one, you teach one. And implementation science, we can put that in there as well, right? You see someone doing implementation science, you do one, and then you start teaching. And it kind of mirrors what I've told you, I summarized about my own journey to date. And then mentoring is very important. Find an implementation science mentor or mentors and be a good mentee. Like a lot of time we focus on finding good mentors, but we don't say as much of people being good mentees. Make it attractive for someone to mentor you. Let them continue wanting to mentor you. You look for mentors to inspire you, but trust me, there are a lot of mentees I work with who actually inspire me to be better as a mentor and be better as a scientist. So, and vice versa, as I said. Find a good mentor and be a good mentee, and be a good mentor to your mentees. Theories, models, and frameworks. Whether you like it or not, you cannot do implementation science without them. So you might as well stop crying and just start working. That's a lesson I've learned. Just do it. Just do it. You can't do it without it. You can't get around them. Do it. Okay? And I want to add here that health equity is already hardwired in implementation science. If you're saying you want to take all the great evidence we have, take it to policy and practice, and make it so that as many people as possible on a population level have access to the benefits, that's health equity. So you don't really need global health implementation science. You're already aligned. You get what I'm saying? You don't need to say I'm doing global implementation science because I want to promote health equity in my work. Both of them on their own already focus on health equity. It is the methodology implementation science that helps us to accelerate the benefits of evidence at a population level. And then really dissemination is harder than implementation in my experience. It is very hard. And I'm not talking about publishing papers. That's actually not that hard compared to the dissemination to policymakers, dissemination to community, dissemination and translation policies. Very hard. Okay, so you need significantly more power to successfully disseminate. And for me, some signs of successful dissemination is like a policy document actually cites your work. I mean, that's like the absolute compliment. Your work is cited in the policy. It's in there. All right. So I think for me, and I think a lot of people are nodding their head, dissemination is hard. So we need to be much more intentional about doing that. And it is not limited to publishing papers. There's much more you need to do. And implementation scientists, I think, should think more like politicians. Strategy and navigating power, negotiating power. You do that all the time, but we have to name it explicitly. We need to think more like politicians. Politicians want to get in power and stay in power, and they want your votes to do that, although some people steal votes and all that. We're not going to talk about that. But so you should think strategically and think about how power works to make you be able to get your implementation science agenda out. We can assume that, I've done this study, it's great. I'm going to talk to policymakers. You've got an appointment, you've talked to them, and you think by the moral sort of, the moral story of it or the goodness of your intervention is going to be taken up, not necessarily. You have to be strategic and make sure that you are appealing to their own investments and their own agenda to get it done. You have to think like a politician. And then it's a sad thing to note, but I think evidence not translating to policy is a failure in IS. So if I'm an implementation researcher and I have, I've done some work in implementation science, and whatever I've done or the results that I have are not translated in policy, I consider it a failure. It doesn't mean that you finish your study this year and next year is in policy. It can be 10 years or 15 years, but as long as it is not policy yet, my work is not done, and I think we should consider it that it needs to get into policy. And there are many ways for it to be reflected in policy. As I said, it can be a citation of your work, but it needs to get into policy, and that is really, really hard. So, and then the last three sort of tips or lessons learned I have are really more personal rules, personal adages for collaboration, and it's not necessarily limited to IS, but a lot of this has come out of my IS collaborations. Be responsive to communication. Somebody either calls you or emails or whatnot. I try to respond within 72 hours to any email, but sometimes it takes a long time. And usually the first thing I say when I email after a long time, apologies for the delay. I've done so many of those emails recently. But be responsive so that people know they can keep coming back to you because you will respond. And once you engage, sometimes then you sort of take people for granted because you know them now. It happens, it's fine. But be responsive to communication and give value. That is so important, I think. Give value, and often give value beyond what is expected. If I bring someone into a research collaboration or to write a grant or do a project, and maybe what I saw on paper and invited them, they're not giving up to it. They're not doing the way they do have the skills, but just not committed, sort of coasting on the rest of the team or whatnot. That is like one surefire way that you either be X'd out of that project, or we might finish the project, but I will never work with you again. I'll really minimize my exposure to you. And I try to think the same for myself. If I've committed to a project with somebody, I need to give value, and it needs to be so good that they're like, I need to work with that man again. And again, and again, and again, they need to come back and keep inviting you to collaborate. So give value and be pleasant to work with. Don't be a jerk. Honestly, this work is stressful enough. Like I can stress myself by myself as far as research is concerned. Like I don't need you to add to that stuff. Honestly, I have enough stress. So just be nice to work with so that if I'm going to get on that Zoom or call you, I'm not like, oh my God, I have to speak with Grace again. They're just going to bring my whole day down, or they're going to be, just doing this whole thing. No, be pleasant to work with. I know we have different personalities, but let it be at least pleasant to work with you in a team collaboration. So, where will my next excellent adventures in global IS take me? I've just highlighted countries that have been relevant to my IS journey. There have been other countries I've been to for infectious disease training or other things. But you can see apart from US, I'm like heavily invested in West Central Africa. Okay, I have to put a yellow circle around Gambia because it was so tiny, so I highlighted it that you couldn't see it. Okay, but that over up there at the top, in the sort of north west there is Gambia. So these are the CAWISA countries, the Central and West African Implementation Science Alliance countries. And I'm trying to focus on these countries in terms of building IS capacity, building the capacity of the health institutions and the academic institutions to do multi-center work. If you look at research per capita, research productivity per capita across Africa, regionally, West Africa is consistently the worst. West and Central, consistently the worst in productivity. It doesn't even matter what the topic or the field is, it's just consistently bad. So we need to make sure that things are better and that our health indices, our public health, the gaps in the MDGs that have gone into the Sustainable Development Goals and all that are better. So my focus is really there. And so as an example, as Grace was saying, that we put together this consortium called the mpox Research Consortium. We put it together around December 2023. We had some grants we wanted to go for. We decided we have to do it together. So we have 6 countries. They are not necessarily the same countries out there. We have, for mpox rec, we have Ghana, Nigeria, Central African Republic, Republic of the Congo, and DRC. Okay, and that's focused on mpox specifically. And we put out a paper just to sort of announce the fact that we've come together and working on this. You see, it's not all Africans there, but this is the Africa-led mpox Research Consortium. We lead, we make the decisions, we implement things, we design things, we consult the communities, and we work with gatekeepers and community entry people to make sure that we are getting the community participation and community input into what we're doing. So as you know, the last 2 days have been really sort of sentinel days in terms of mpox. Africa CDC announced the public health emergency of continental security. And then I was like, all right, let me just start doing some stuff to deal with this. And then like 24 hours later, the WHO has the public health emergency of international concern. And so it's the second one for mpox, right? Barely a year and a half or 2 years after the end of the first one. So you can see how the CAWISA countries in the circle in red over there overlap with the mpox rec countries. So there's a lot of work we'll be doing, but I think that it's better to do these things in numbers. There are so few implementation scientists in Africa, and particularly West Africa. It's like sometimes someone will call me and say, can you work on this grant with us? And I'm like, well, why didn't you go to my colleague like HSO Naziano? And he's like, well, we called him, he said it was busy, and he said we should call you. Okay, so it is very, very few people. So it's good to sort of, come together and notice that even though there might not be a lot of implementation scientists, all these people on this author byline here are distinguished scientists. They might not be distinguished implementation scientists, they're distinguished scientists. So sometimes my role in these things is simply to do implementation science, right? And of course, if there are no pediatricians, I will make sure that we attend to children. So this is where it's going now, emergency response, pandemic response, and infusing implementation science into those activities. So I just want to end here and have some appreciation and acknowledgements, of course, WHO, for giving me my first opportunity to lead an IS study, Prof. Lee Cornelius for coming in with his social science karate skills. UW, honestly, UW has been very helpful to me for really helping me to start learning about implementation science. I mean, I put that fundamentals of IS course completion so fast on my BioSketch, I'll tell you, because that gave me some validation, right? And of course, the online IS resource hub. Chandy John, I want to thank him. He's not an implementation scientist, but he's the first really solid mentor, long-term mentor that I've had who really helped me figure things out. Of course, he's not an implementation scientist. Mentees often follow the footsteps of their mentor, but Chandy and I had that discussion. He said, you may not want to do basic or translational medicine or immunology, and it's okay with me, but I can't mentor you in an area that I have not worked. But he let me go with his blessing, right? And helped me figure it out. And I've come full circle, and I'm literally now sitting in his office I'm leading the global pediatrics program, but the research I'm doing is different from his. And fun fact, that his sister sitting right here. I'm just happy they are such a cool set of people. Really, well done to your parents. Yeah. So, and I want to thank my Nigeria research teams, my present members and my past members who left me in Nigeria. Gift, thank you. And then I want to shout out to the Moment car. You know that car, honestly, you probably never had a presentation where a car was given acknowledgement. Here, SVB was bought with the Moment money. There was a second car that we bought, but this car has been with us. Like the minute it landed, we were driving to Mina in Niger State. That car has been, it's still there. It's still there. So I want to thank Kia SVB, out here at one of our primary healthcare center study sites. And I want to thank my collaborators, research groups, NISA, CAWISA, AHISA, all the AHISAs past and present, and mpox rec. We have so much to do, and I'm excited to see what we can do. And of course, AfriHealth, which is the African Forum for Research and Education in Health. They are continent-wide, and we've done a lot of great work with them. And of course, to you, today's audience, thank you very much for your time and attention.
Was fantastic. We have 10 minutes for questions.
Yes.
I have a question. Your slide in terms of, I think it was your 18 list of how we get there. Number 6, totally agree, think like a politician. Number 7, policy and translation and the failure in terms of IS. When you say policy, can we define that? Because many people define policy differently. Some people define policy with a little p. If your IS is translated to guidelines, at the clinical level or guidelines, in an institution, that's success. Other people like, no, policies need to be at a national level, big P. They need to be, universal, that's success. So for you, what are you defining policy to be?
For me, it's big and small.
Okay.
It's big and small P. But for instance, if I'm talking about a certain field, like if you're doing quality improvement, it's probably a small P at your institution or within a certain network, defined network. But for me, working with pediatric HIV in Nigeria, given how much of a problem it is, I'm looking at national, right? So if maybe our implementing partner, IHV Nigeria, decides to, they drew from the Moment study and started doing their training of mental wellness model. But I didn't go beyond that, I'm not done. So it also depends on the thing you're talking about. How much reach do you need it to get to make a population level outcome? And the population level can be, a certain defined place or wider.
So it's contextual.
Yes, again, yeah, back to that.
I was paying attention. Okay. Got it.
So thank you for that question. Questions, comments, disagreements? Yes.
Nadia, this was a spectacular talk, and I don't think I have laughed this hard in ages. My abs are so sore from it. Thank you. I love hearing about this journey that you had, and I've been a long-term admirer of all of your mentorship work in particular. And I'm curious, what's the future of CAWISA? This is my first question. And then the second, I'm very curious for those of us who are not classically trained, or those of us that are getting classically trained, newly minted doctors in the room. What is the future that we should be supporting to scale?
Thank you. So for the future of CAWISA, I'll tell you that one of the things I've learned from CAWISA is I've had to make up some of our goals as we've gone along, because things have changed. We were established two months before the pandemic. All right. And so I've learned to go with the need, right? Adjust to needs and sometimes rapidly changing. But CAWISA right now, I thought that we would be focused on mentoring individuals that are postdoctoral investigators who want to be independent, and then also working on multi-site studies with the different centers of excellence that we're working with in CAWISA. But I realized that we are trying to train individual postdoctoral investigators on IS when their supervisors and seniors and mentors don't know much about IS. They are distinguished researchers, but they don't know much about IS. So we had to step back and now do training for groups of people at these institutions. So we've done the training in Ghana, University of Cape Coast, we've done training in Gambia, we've done the training in Nigeria, we've been planning the Cameroon and DR Congo one now, and training around the CAWISA scholars, golden scholars, So realizing that they can't be mentored by someone else on IS when their mentor doesn't know much about IS. And so in doing that, you realize that there are some people who actually have become high affinity to these things and really want to learn more. And that is how the UO1 that I just talked about. There's 3 PIs, there's myself, and then one of the other people is a CAWISA mentor in Ghana who was just so focused on learning IS and just absorbing it that she was writing this grant with another person and said, you have to bring Nadia into this grant. And that's how we got our first sort of big IS grant. Yeah. So the second question was about where, I think, telling you guys where I think you should be focused on, right, as newly minted or on your way in the IS field. I think that we should, first of all, we should not limit the discussions on health equity to global health only. And I'm saying this as on the other side, global health practitioner too. Make sure that you're continuing to look at health equity in implementation science. And the other thing I think I told somebody else was that, I think it was you, Sarah, where I was saying that if you are happiest working with a particular population in a particular place, don't let somebody convince you to do otherwise. Stick to that, because the reason why I can, I'm getting older, so it's harder to do this, but I can sleep to 4 a.m., wake up, keep up to 4 a.m. doing something, because I love the population I'm working for. I'm working for children, right? And I love the place I'm doing. I'm doing in Nigeria and Western Central. That is my place. So if there's a certain group or place that you have affinity to, you want to do that, do yourself a favor and focus on that. Right. I actually don't like mentoring people who are not into what I'm mentoring them about, because I see it. I'm like, you don't really want to do this. And it's a disservice to yourself, but it's a disservice to me as well, because I'm putting a lot of energy in a direction where it won't, I call it dead-end mentoring. It's not going to go anywhere. And at the same time, you might want to work with me, maybe you think I'm fun and whatnot, but you want to do something else. Let me refer you to somebody else or sort of put you in another direction. What Chandi did for me, right? And so those are some of the things I'm saying. But in terms of topic area, honestly, I am a Peds ID doc. Infectious disease is not focused on one organ. It's from the top of your head to the soles of your feet, anything. So the same way, implementation science, you might say I'm an HIV implementation science person, but I found myself working on that last UO1 is a cancer grant, but the methods are still the methods. So also, while you were focused on areas you like, also, keep an open mind, because, and that grant really, it challenged me, but I really went all out on that area and I was proud of what I was able to do. So I think those are a few things I have to say.
One back there.
Yes.
Was building on this question. So a lot of what you've done is in the research space, and with CAWISA, that I think is mostly, I'm assuming, geared towards researchers. But I think my question is kind of what comes next, and do you see kind of a future in also building up implementation science expertise across the continent, or, for example, supporting building up those expertise maybe more in Africa CDC and some of the more maybe programmatic and side as well.
And so I will just add that I've been thinking about that, right? And we have a small operating budget. We get funding from Fogarty's AHISA, Adolescent HIV Implementation Science Alliance. And one of the things that we want to look at in terms of sustainability is making sure that we are writing grants that supports the research but supports our operations. And so it is really that operational funds that can help us branch into sort of pet project areas. And so we want to look at other places too. There's been even places outside of West and Central Africa. There are people in East Africa basically heckling me at conferences at my CAWISA poster and saying, why can't we be part of it? They keep heckling me, and I understand there's a lot of me. So one thing to be able to do that is you need funding to operate, to get more funding. And this is the first really big grant, the one in Ghana. So we can imagine, I'm looking at imagine how many people we can train, you know. So I'm already asking my Ghanaian colleague to start finding some postdocs people, or people who are maybe still be, studying, but to train. So we look at expanding, but we have to be very cognizant of limitations of funding, and also the fact that nobody is paid on CAWISA. Like, I finally have to put in I think 3% FTE or 2%, because my own institutions are like, why are you working for free? But none of the other CAWISA faculty are really paid, so we are operating on very bare bones things. But I'm seeing how much, impact and inspiration and motivation from going and training people for 2 days in implementation science. Now I go back to some of these schools and they're like, I put in a small implementation science grant. I'm like, yes, so little ripples, but I think down the line, I'm going to write a grant. Like the D43 training grant I have in Nigeria was actually built from some of the experiences from CAWISA, but it's focused on Nigeria. So down the line, I want to write bigger grants to focus regionally, and then looking at also community engagement, really doing that well. So this mpox thing, one of the directions in which we are going, and in mpox rec, I'm there for, believe it or not, social behavioral science, community engagement, and implementation science. I'm sorry, Kristen, and all the classically trained social scientists. That's where I've been put in. And so I've actually been working, but there's a social scientist, an actual trained social scientist, in Pittsburgh, who is working side by side with me to write, engagement plans, and then looking at qualitative studies to really gauge vaccine acceptance and hesitancy. So a long answer, but sorry. No more questions?
Let me just comment.
Yes.
So I would like to say thank you to the Moments Project, because that's one group we're very proud of in Nigeria. So I'm one of the lead facilitators in the country, and they were so proud of our mentor mothers. So we're conducting studies on tax shifting, and involving the mentor mothers, and that's a very strong group. So just to say big thank you, because what you started years back has its impact and its effect. So when we're looking at strong groups, we look at the mentor mothers, and now engaging in other projects, we're thinking of tax shifting activities for them as well to engage in, and they're doing so well. This is years after. So it was interesting to know that this started from you. I came in and I had joined the Moments project, but I started facilitating and training the mentor mothers, in the country, and then just to see that you started it. I would say thank you on behalf of the mentor mothers.
Thank you so much. At some point, PEPFAR defunded a lot of programs. And one of the programs that was under threat was the mentor mother program. And to have that, the study wasn't done then, but it was still running. I'm like, what do you think we're going to tell WHO? WHO thought it was important to fund, and you want to defund mentor mothers. Like, it was going to be a very unpopular move. So they held on to funding them, even though it was low, but they still funding their activities. So sometimes just having the grants there, makes it hard for people to defund the idea or remove that service. So thank you so much.
That's a really good way to end it. Yes. Thank you so much.
Attend D&I for more of the same. Oh yeah, are there people still, or maybe it's probably ended. I don't know if anyone was, how am I going to do this? This is potluck prep. I wonder if,
You try to escape.
Oh, escape.
Yeah.
All right, so
It's one chat.
okay, let's see. So we are going to look at questions from the chat. Okay, I did not. Thank Thanks a lot, Nadia, for such a great session on making time for adult vacation. Yes. So I met Grace earlier. Okay, thank you. And I don't think there are any questions. Okay, Chidozie, Aisha, I know some of these names. Maha, hi Maha, thank you. My able, very brilliant collaborator from Egypt. Okay, any questions from the group online? And Michelle? Yes, they are. Okay. All right, we're going to end now. Thank you for attending. Thank you so much, those online and those here in person. Thank you.